So the talk today is alcohol a cure for what ails you or a public health menace? Tim was very nice in his introduction. He said that I was a professor. That's actually not true. I'm an associate professor. Maybe one day that will change. But we're going to run through today. So I have no conflicts of interest. That means I don't get any money from alcohol companies. My research is funded by CDC in the U.S. and by the National Institutes of Health. And if we had a bigger audience here, I was going to point out to people that when, a scientist says they have no conflicts of interest, they're doing that as sort of a badge of honor. But really it just means that we're poor and that we really could use more funding, because we would love to be funded by anyone and we could then claim a conflict of interest but be rolling in cash. So if you look at this slide, actually, I've used this slide for a couple of years now, but it bears an uncanny resemblance actually to Professor Stockwell. There's some facial hair and some glasses, and it turns out that this picture was taken down on Douglas Street in Victoria, and I'm not sure who it is. So anyways, today we're going to talk briefly about the harms from heavy alcohol consumption. Then we're going to spend most of our time reviewing the health effects of moderate, or what I'm going to call is low volume alcohol consumption, and with a particular focus on its potential benefits with respect to cardiovascular disease. And then we're going to talk a little bit about sort of how that all shakes out in terms of clinical or public health recommendations. All right. So in terms of harms, most people are generally familiar with the idea that alcohol can cause a number of harms. Come on in, we're just beginning. So worldwide, it's estimated that about 6% of all deaths in the world are caused by alcohol. That comes to about 3.3 million deaths annually. Now in Canada, because I'm not from Canada, as you know, so I did a little hasty last-minute homework. So I found out yesterday that Canadians drink 50% more on average than the rest of the world does. That Canada's experienced about a 15% increase in average consumption between 1996 and 2010. And in Canada, approximately 8% of all deaths occurring before the age of 70 are accounted for by alcohol, or it comes to about 4,000 net deaths annually. So I think, again, most people wouldn't be too surprised with the idea that alcohol is a risk factor. And it's a risk factor for more than 60 different adverse outcomes. And what I want you to do is think about these different outcomes along two dimensions. One of them is the idea that some of them are more strongly associated with drinking a lot, and versus others of them may be also caused by not drinking a lot. And then the other important dimension to consider is that some of these adverse outcomes related to alcohol are related to drinking to get drunk or from acute intoxication. Those would be things more like injuries and violence. And then other of these diseases are more associated with how much people drink on average or in total. So things like liver disease or cancer or alcohol use disorders themselves are a little bit more associated with sort of average consumption. Yeah.
Am I pressing your mic?
Oh my gosh.
We're picking up there.
We're picking up? Okay. Oh, now I'm really reverberating. So we should also, though, in addition to sort of enumerating the harms, we should also consider the possible health benefits of alcohol, because there's a substantial literature in that as well. And if we could go back all the way to Pliny the Elder, he was a Roman dude in the 1st century AD, who had a nice quote. He said, "It's hard to say whether wine does good to more people than it harms. Medical opinion is very divided." So this idea that a little alcohol might be good for you has been recognized for many, many years. Now, Americans, we're not very cognizant of history, and we don't really get too much of an education in America. But for most Americans, this idea of the health benefits of alcohol really sort of took off in the early 1990s, in 1991 specifically. And there's a very popular Sunday evening television program called 60 Minutes that lots of people watch. And on 60 Minutes, this guy, Morley Safer, who's the host, did a very interesting program on the so-called French paradox. And the French paradox, for those of you who aren't familiar with it, is this idea that, oh, we think of the people in France, they eat lots of butter, and they smoke cigarettes, and yet they seem to live a long time. So that's what's been called the French paradox. Well, in 1991, this was sort of brought to the attention of Americans on 60 Minutes, where Morley Safer concluded that now it has all been but confirmed, the answer to the riddle, the explanation of the paradox, may lie in this inviting glass. And here he is holding up his glass of red wine. And then Curtis Ellison, who's actually a professor at my institution, was on that program. And he said, there's something about the French that seems to be protecting them, and we're not sure what it is. We're looking for it. So that's where this idea of the French paradox really got going. And the resulting demand for red wine, the New York Times wrote several years later, was seen as potentially the biggest boon to the wine industry since the repeal of Prohibition. Now, I guess you guys had Prohibition in Canada too, is that right?
Yes.
Yeah. So that's where it got started. And this is a slide I stole from Tim, but I like it because I think we take it as a common starting point. We will concede that until recently, at least, there's been a broad scientific consensus across multiple disciplines that alcohol use in moderation confers health benefits, particularly in relation to coronary heart disease, and that is evident in the J-shaped relationship between drinking and all-cause mortality. So we're going to talk a lot about J-shaped curves today. So let's get to know our J-shaped curve. So the first thing to note is, remember I talked about two dimensions of alcohol consumption, which is per occasion consumption, or how much people drink when they drink, versus average consumption. And most of these J-shaped curves we're going to see today are based only on average consumption. So if we look at this one, for example, which is from a large meta-analysis of the relationship between alcohol consumption and total mortality, this axis here shows the risk of dying. This risk of 1 corresponds to no increased or decreased risk, and anything above the line is increased risk, and anything below the line is decreased risk. So here is an unadjusted curve of all of these studies, and what it's showing is that, lo and behold, at these different levels of alcohol consumption, there's a lot of it is below the line. Now let's quickly look here at the x-axis here. This is in grams of ethanol per day. And this says drinks, but this is actually in Europe in British drinks. But in Canada and US, it's about 14 grams per. Is it for Canada? Is it 12 or 14? 13 and a half. So for the US, it's 13 and a half or 14. So that's now the interesting thing is that the lowest risk of death occurs. And here's the fully adjusted curve here, this dark one, occurs at about 7 grams of alcohol per day. So that's actually about half a drink a day. So not very much alcohol, actually. And the other thing I want to show you is that when you statistically adjust the data to account for important things, which we'll discuss in a minute, that this risk relationship changes quite a bit. So here's the unadjusted curve. And then once it's adjusted, all of a sudden the protective effects at these lower levels of alcohol consumption, say up to a couple of drinks a day, there's less protection. Here there's lots of protection. This is a relative risk of about 0.65. That means you have the 65, if you were in that category, you have only a 65% chance of dying compared to somebody who didn't drink. Okay? So that's the J-shaped curve. So adjusting changes things a lot, and we'll return to that theme in a minute. Now, this is actually from a different study, but underlying that curve that was composed of multiple different studies, and it's looking at all types of mortality, we have to remember that there's actually a bunch of different curves of all the different causes of deaths that feed into that bigger curve. And right off the bat here, you sort of look at this and you say, because here's a curve showing alcohol-related cancers. And wow, look at, there's a protective effect at low levels of consumption. Is that likely? Or this other curve here for injuries, again, showing even a protective effect at low levels of consumption. Well, how is that? Because alcohol, when you look at when people drink, it's really only a risk factor. So why is it that when you look at average consumption, you can see a protective effect for any amount of alcohol consumption with injury? And then you dig a little bit deeper and you realize that there's actually tons of studies about different outcomes in which moderate drinking is associated with less risk of a variety of health outcomes, some of which just seem a little bit fishy, and I've put some of those in bold. And I'm saying that they're fishy because, as a physician or in clinical medicine, we just really don't have a biological sort of explanation as to why that would be the case. So things like the idea that alcohol should protect against asthma, or the common cold, or hearing loss. Alcohol is a neurotoxin, so if it doesn't make sense that it would be associated with nerve damage that causes hearing loss. Or liver cirrhosis. Isn't alcohol supposed to be a risk factor for liver cirrhosis? So it just makes you sort of wonder. And one question whether, in fact, this is really plausible or not. Now, before we go further, some people might say, well, why question the evidence around low volume consumption? I drink alcohol, many people drink, and why not be happy that it shows that, we all like studies that show that coffee is good for us, or sex is good for us, or chocolate is good for us, so why not, alcohol? And I guess the reason is that, first of all, we're, scientists and we like to know, and then second of all is that people's conclusions scientifically around low levels of consumption actually are very important. And they're important because they do influence and have influenced national drinking guidelines. This idea of health benefit is used fairly extensively by the alcohol industry to oppose alcohol policies, like raising alcohol taxes. Because scientific conclusions about lower level drinking can affect public attitudes about alcohol more generally. So ultimately, these opinions about the effects of low level alcohol consumption can, in theory, contribute to harm. And by the way, people, because it's a small group, people can ask questions or interject or throw things during the talk if you want. But we're going to talk a little bit about some reasons for caution from a sort of a scientific perspective. So the first thing is that there's no randomized RCT, randomized controlled trials of any mortality or morbidity outcome. Mortality is medicalese for death, and morbidity is medicalese for disease. So there are no randomized controlled trials, and they're only observational studies. So in the US and in Canada and most developed worlds, or most countries in the developed world, if you approve a new pharmaceutical agent, for example, you rely on data from randomized controlled trials. And the reason for that is that we can even point to a number of recent examples where observational studies, where we just don't randomize people but just observe them in the natural world, have suggested benefit only to be later contradicted by data from randomized controlled trials. And the one that people are probably most familiar with is hormone replacement therapy. Early in my career as a physician, I can't tell you how many women I stuck on hormone replacement therapy after they reached menopause, and we found out later that that was probably, on balance, not a good thing to do. So I'm not going to try to get too much into methods, but I thought for the audience here, again, mostly those that weren't paid to come, that there are two things I want to talk about from a methods perspective that I think are important to understand. The first is this idea, and these are limitations I should mention that apply mostly to observational studies, more so than to randomized studies. But the first one is the idea of confounding, and confounding is really getting to the heart of the difference between association versus causation. So in technical terms, confounding is in the case of alcohol, is the appearance of benefit from alcohol due to favorable factors that are associated with drinking but that are not caused by drinking. Okay? So it's Basically, the idea that if alcohol is keeping good company with other good stuff, then it's going to make alcohol look good by hanging around with those other factors. In a study that Tim had mentioned from more than 10 years ago, among U.S. adults, and there were about 300,000 adults from the largest telephone survey in the world, we did a very simple thing, which is just to compare non-drinkers with low-volume or moderate drinkers for 30 different CVD, cardiovascular disease-associated risk factors. And of those 30 factors, we found that 90% of them were statistically more likely to be associated with non-drinkers. So in other words, non-drinkers were more likely to have things that made you more at risk for cardiovascular disease. This was like a staggering finding to us. And it was just, and again, we weren't trying to, the idea was not to prove whether this meant that any of the existing science was wrong. It just was a gigantic red flag. And not only was it more common for 90% of those risk factors to be associated with non-drinking, but for things that we looked at progressive levels, like the risk of being obese, and if we looked at progressive levels of obesity or progressively higher levels of education, each progressive level was more strongly associated with being a non-drinker. So enough about that. But, so the question is, you could say for some of these things, maybe alcohol caused these good things that we observed. But a number of them seem like things that really wouldn't be caused by alcohol. Like, why would low-volume drinking, in adulthood, cause people to have better teeth? I mean, literally, fewer dental extractions. Why would it cause them to have higher income, or to have better health insurance, or to have achieved a higher level of education in young adulthood, or to enjoy more leisure time physical activity, or to be less likely to be divorced or to have better mental health? So these raises questions about whether alcohol is causing these things or is merely associated with these things. Now, our study was a study of all U.S. adults, so from ages 18 and up. But similar studies from other places, in this case the UK, have looked at this starting really sort of coning in on younger ages. So in this study by, I never know how to pronounce his name, well I guess Fat is the last name. You would have thought that would have been my study, but but anyways, they were looked at poor health in this British cohort, defined as having a history of long-standing illness. So poor health and social disadvantage, meaning lower income and lower educational levels, were both associated with non-drinking status and within that never drinking status among young adults from young ages. So this was a study of people ages only 18 to 34, and these associations persisted into adulthood. So the reason why I think this study is also important is that if we really thought that alcohol was causing these benefits, we might expect those differences to emerge later in life after people have been drinking for some time. But in fact, it appears that these differences start from relatively younger ages at which it's unlikely that alcohol, for example, is going to improve your educational level if you're in high school. So the conclusion is, basically, from a scientific standpoint, is that non-drinkers and low-volume drinkers are not really comparable. Most studies don't control for or can't control for nearly as many factors as we attempted to look at in our simple study. And, I can go into all the reasons why it's just difficult. So the question really becomes, and I think I've sort of covered this, is moderate alcohol consumption a marker of social advantage or its cause? And if you believe that at least some of these associations are associative and not causal, then one must arrive at the conclusion that in general, confounding is going to bias studies in favor of moderate drinkers relative to non-drinkers. So the second and final methods thing I'm going to just touch on today is the idea of selection bias. So selection bias is the systematic error in the selection, enrollment, or participation of study subjects that distorts the relationship between an exposure, in this case alcohol, and a disease outcome. Without getting too technical, if you think about it, in these observational studies where you pick up people who are moderate drinkers or low volume drinkers, you can sort of imagine, or you can sort of see, that they're a select group. They chose to start drinking way back when. They didn't die from their drinking. They didn't quit. They didn't become heavy drinkers, because otherwise they wouldn't be, your moderate drinking comparison group. And they were sort of willing and able to participate in a study. And you can also imagine, without too much difficulty, that those people may be different from, say, lifelong non-drinkers who might have been randomized to start drinking in a trial. Now, this is a slide that that was published in a paper that we did last year, and it's showing some of the different types of selection bias that can occur. So this here shows sort of a flow chart of what can happen. People can drink or not drink, and then they can die or not die, and then if they continue drinking, they can either quit or become a heavy drinker or a moderate drinker or a non-drinker. Now, these are all going to happen in order. That's interesting. Okay, so I'm just going to put all the X's here for a moment. Okay. So I'm not going to go, we already talked a little bit about how maybe from birth people who choose to drink and not to drink may be different from one another. I don't know if that's again more of a confounding thing. It's not technically selection bias, but it's related to it. Now, the other issue is that we're going to come back to is that when you do studies, observational studies, you'd still like to pick people up from the time their exposure begins until the time you see what happens to them. But when we remember, most of the studies that we've used to study alcohol were not actually designed to study alcohol. They were designed to study things like heart disease and cancer. And so most of the big studies that we used to study alcohol, the effects of alcohol consumption over time, enroll people, let's say, in their 50s and older. Well, most people start drinking in their mid-teens. So now you've got this 30 to 40-year gap between when people start drinking and when we begin to study them. So what can happen in that gap could introduce a lot of bias. So, for example, if people are more likely to die from alcohol, but you're not there to witness it, then their bad outcome doesn't get captured. So that's another kind of selection bias we're concerned about. Then there's this other idea here, the people who quit drinking, and that's where Professor Sockwell and Dr. Chow have done so much work, which is on this so-called sick quitter bias. The issue there is that people who stop drinking alcohol are generally frail and unhealthy. And the reason for that sometimes is because of the alcohol consumption itself. But more often it's just that people get sick or they get weak for another reason, and most people then choose to stop drinking. The point is that if you just ask very superficially in a survey or a study, do you drink or not, and somebody says no, that in most developed countries, those non-drinkers are actually more likely to be former drinkers than they are to be never drinkers. So in that way, they're actually one of the drinking groups. They're not the non-drinking groups. In the old days, in very unsophisticated study, these quitters, who are technically non-drinkers at the time they're assessed, would have been lumped back in with the non-drinking group and made them look bad, because you're essentially throwing a bad apple into the rest of the non-drinking group. So nowadays, people are aware of this, but even if you just exclude these people from your studies, it's still not fair, because they really were originally they were drinkers, so they should, like in a drug study, they should stay with the group they started with. But anyways, the net effect of this is you end up comparing this group of moderate drinkers to a group of non-drinkers, and it doesn't represent all the things that can happen to you when you start drinking. Now, one thing I'm just going to jump back to is this idea that in this gap period, what can happen? How can there be a bias? Well, the issue is that if you're at a young age, before you might be in a study, if you're more likely to die from alcohol than you are to die from a lack of alcohol, then you're going to make the drinking groups look good. So the issue there is, and this is a terrible, we're going to fix this slide, but this is a new experimental slide. So when we look at this using data from the United States, what we find is that in fact it's the case that almost 1/3 of all deaths that are caused by alcohol consumption happen before the age of 50. But even if we model in that there may be some lives saved from cardiovascular disease, only 4% of those lives saved occur before the age of 50. So the idea is that if we're using a bunch of study populations of people typically age 50 and older, a lot of their harms from alcohol have passed them by, and all of the benefits lie in the future. The point is that the age at which you study these people is going to have a big influence on the risk relationship that you observe. So how does all this theory translate into studies in which people try to account for these problems of confounding and selection bias? Well, that's where, again, Drs. Stockwell and Chow have done so much great work, and it's CISUR's own meta-analysis of 87 different studies looking at alcohol and all-cause mortality is very informative. And what they tried to do, and they did, is they tried to do a number of appropriate statistical adjustment techniques to address these problems of confounding and selection bias. And so this, again, is showing relative risks for different categories of drinkers, former, occasional, low, medium, and higher drinkers. And this is unadjusted analyses, and then this is analyses with statistical adjustments to address these problems. And what you can see is that after adjustment, the risks of all these drinking categories for death are higher. Or the protective effects, for example, among occasional drinkers, becomes less. So this shows that when you try to account for these sort of theoretical problems with the data, the protective effects seem to become less. So let's look at this in a graphical depiction. This was put out by CISUR. This is, if you look at the unadjusted analysis, this is the group of abstainers here, where the blue line is, that's a relative risk of 1. There's no increase or decrease risk. There are reference groups, so-called. And you can see that as you come down here, occasional drinkers and low-volume drinkers, big survival advantages. Okay? And then only once you get up into the high-volume drinkers and above that you start to see excess death. But now compare that after you do the adjustment and you pull former drinkers out of this abstainer group. Look what happens. So now, again, here's your former drinkers. Now your abstainer group is more appropriately composed of never drinkers, and the whole curve is shifted up, meaning that these protective effects are smaller and are not as observed over as wide of a range of consumption, and the harms appear to be greater. So this is what happens. Let's look specifically at one of those dots on the line, the low-volume drinking group. Those are our moderate drinkers, the sainted moderate drinkers. And we can see that here in this box of relative risk estimates, and as we progress up the box, we're controlling or accounting statistically for more and more of these factors, that the apparent protective effect of low-dose drinking becomes less and less. So this apparently makes a difference. Now, what about cardiovascular disease? Because I know that people here have heard a lot about cardiovascular disease and low and moderate drinking, and as the slide said, low to moderate alcohol consumption is associated with positive effects on cardiovascular health. And I might add that if you look at the total mortality curves, any of those parts where you're getting protection, it's all being driven by reductions or apparent reductions in cardiovascular disease. So let's pull back the layers of the onion a little bit for cardiovascular disease. And what we're going to do is just run through the relationship of alcohol with a variety of factors that lead up to cardiovascular disease, so like HDL and hypertension and diabetes and obesity. And then we're going to end with a little discussion about studies that have looked at actual coronary heart disease outcome itself. So in this discussion, we're going to just talk about 3 types of study designs. The observational studies we've already discussed. Then there's something called Mendelian randomization studies. Let's see, why is my pointer recording enabled? What have I done? Still working?
Use the pointer.
I can use the pointer. That's okay. So next we'll talk about Mendelian randomization studies, and I'm just going to discuss that very quickly because I don't know if any of you heard of what a Mendelian randomization studies? Okay. That makes me be cautious because I'm not an expert in that. And third, we'll talk about randomized clinical trial. The main point of this slide is that in general, these types of studies are organized in order of increasing strength. So the one that I'm going to talk about quickly is the Mendelian randomization study. The last time I gave this talk with Professor Stockwell, actually he advised me not to get into this. But because you're an exceptionally intelligent audience, I'm going to just touch on it briefly. So the basic idea here, just so you have some sort of sense, is that a Mendelian randomization study compares people with and without genetic variants or genotypes that are associated or actually causally related, we think, with different levels of alcohol consumption. So it sort of gets you to the same place as if you asked somebody, but not quite. And the reason why there's some advantages of Mendelian randomization studies compared to observational studies is that when you're comparing these genotypes that cause slight differences in alcohol consumption, the good thing is that the genotypes are randomly allocated at birth, and so in that way you hopefully reduce differences in potential confounding factors the same way you would from a randomized clinical trial. Also, because genotypes are present from birth, they cannot possibly be caused by diseases that happen later in life. In other words, there's this question in observational studies is what's the chicken and what's the egg? Well, when you study a genotype, you know that came before whatever your outcome is, the death or the heart attack or whatever, and that's very helpful. And the other thing is that genotypes don't change. Remember how we were talking about how people can drink and then stop drinking? Well, and that's how you don't know how to deal with them. Well, genotypes don't change, so that has some advantages. So, with that in mind, and we're sort of rank ordering the quality of the evidence, we'll jump ahead and we'll talk about what do we know about the relationship between alcohol and HDL, aka good cholesterol, and as you'll see in a little bit, what we should really say is, I'm going to have to change my slide because it should be formally known as good cholesterol. So, both observational studies and Mendelian randomization studies show that alcohol raises HDL, good cholesterol. That sounds good. And also there's been a number of actually short-term clinical trials, randomized clinical trials, that show that if you stick people on alcohol, a glass a day of something or other, for a few weeks, actually their HDL will go up. And it will go up by a pretty, like a meaningful, like 5 or 6% maybe. So that's good. So alcohol does cause HDL to go up. But what has changed in the past 5 years is that we now pretty conclusively know that HDL is actually not in the causal pathway of heart disease. Why do we know that? Why is the good cholesterol no longer the good cholesterol? Well, the first line of evidence is that people have done big meta-analyses of all those statin drugs that change people's cholesterol levels. And as we all, or hopefully many of us know, that these statin drugs have a really big effect on changing people's LDL, or the bad cholesterol. That's what they were invented to do. So when you do studies where you take into account the effect of these statin drugs on LDL, there's no independent effect anymore of HDL. So HDL does not appear to have any independent effect. Second of all, there's now been 4 or 5 drugs that have been either available, like niacin, or have been developed that very effectively raise HDL. And all of those drugs have failed in clinical trials to reduce cardiovascular disease. And third is that there's actually been a very nice Mendelian randomization study of a gene that causes people to have higher HDLs, and that gene is not associated with a reduced risk of heart attack. Therefore, the current preponderance of the evidence overwhelmingly says that HDL is actually not in the causal pathway. I mention this because HDL raising by alcohol has been sort of the poster child, if you will, of the biologic plausibility of why alcohol could reduce heart disease. So let's look at blood pressure, another important risk factor for heart disease. So observational studies mostly, not always, but generally show linear relationships, meaning no J-shaped curve, that more alcohol is associated with higher blood pressure and an increased likelihood of hypertension. Again, Mendelian randomization studies support the idea that the more alcohol you drink, the higher your blood pressure, the more likely you are to have hypertension. So that's the next one. Alcohol and diabetes. Again, there's a lot of publicity around the idea that moderate drinking may protect people against diabetes. And when you look at observational studies of the relationship between alcohol consumption and diabetes, that indeed appears to be the case, that it does appear to be protective overall for diabetes. And we're going to show a few more slides about a meta-analysis by Not et al. That looked at this. However, when you look at Mendelian randomization studies, and there are at least two of that I've found that I'm aware of, that alcohol is not protective for diabetes in Mendelian randomization studies, and there's actually been a number of short-term and intermediate-term randomized control trials, and a meta-analysis of those find that actually alcohol consumption, including low-dose alcohol consumption, has no effect on fasting blood sugar and no effect on hemoglobin A1C, which is the main test we use to follow people with diabetes. So I'll just jump back to this meta-analysis of observational studies, because I think it's interesting. This again shows another J-shaped curve in which it appears that at consumption of less than up to about 60 grams a day of alcohol, which is like 4 drinks a day, wow, it's pretty much on average, that you actually have a protective effect for diabetes. But now watch what happens and see if you remember something we've talked about before. When you look at the relationship between average daily consumption and incident type 2 diabetes, something happens when you divide these non-drinkers into never drinkers versus former drinkers. So if you look at this curve, the blue curve, the lower dashed blue curve, refers to non-current drinkers. That means everyone that just said, nope, I'm not drinking at the time that they were enrolled in the study. But if you pull those people apart and then you look at there's a red dash curve, those are the group of people who report never having consumed alcohol. And what you can see is that the dashed red curve doesn't really dip below the solid line of relative risk of 1 and goes up afterwards. So again, it's like the story we were telling before from Dr. Chow's meta-analysis, is when you pull apart former drinkers out of the equation, that you get a different result. How about alcohol and body mass or overweight? Well, again, observational studies show J-shaped curves in which lower body mass index is achieved, or lower rates of obesity are observed at low levels of alcohol consumption, and then it goes up for higher ones. But again, we have a couple of Mendelian randomization studies that show no J-shaped curve and only a positive relationship between alcohol consumption and body weight. And then we also have mixed findings, but predominantly findings for other markers of vascular health. So carotid intima media thickness, that's just a measure of how stiff the blood vessels are. It's related to high blood pressure. Again, most of those studies show that any alcohol consumption is only associated with an increase in arterial stiffness. And most, but not all, studies show that the more you drink, the more likely you are to have a higher coronary artery calcification score. So these are all sort of risk factors or biomarkers for CVD. But what about if we dig a little bit more into the relationship between alcohol and CVD itself. That's Kitty Coleman State Park. Those are my daughters introducing cardiovascular disease. So we've already talked about, I think the slides got out of order. But anyways, we've already talked about the fact that for observational studies for cardiovascular disease, it's another sort of the classic J-shaped curve. But a few years ago, I think there was an important study that came out, a Mendelian randomization study, that in fact showed no protection for low-dose alcohol from coronary heart disease events, and if anything, a slightly increased risk. So this was a study of 260,000 persons of European ancestry drawn from 56 studies. So they had sort of information on all these cohorts in terms of what they drank, and they also had samples of their blood from which they could do this genetic testing to do the Mendelian randomization study. The outcome was CHD events. The variant genotype they confirmed was associated with less consumption across all levels. And the key finding is, I'll point for this one. The key finding, so the thing to remember is that if you have the gene, you drink less. So if you look, let's see right here, okay, among drinkers, having that gene conferred less likelihood of CHD events. So having a gene that made you drink less was related to having less heart attacks and those types of things. But importantly, among non-drinkers, having that gene didn't make a difference in whether you had CHD events. Why is that important? That's important because somebody might rightly say to you, well, what if having that gene makes you have less heart attacks, but it has nothing to do with alcohol? Well, this shows that just having that, if you don't drink, that just having the gene doesn't really change your risk of having a heart attack. But if you drink, you're going to drink less, you have less risk. So this actually turned the J-shaped curve on its head. And I don't think I explained it very well, but the bottom line is that it was a paradoxical finding. Most people would have thought that when you drank more, you'd have less heart attacks. This sort of suggested the opposite, including among people who drank, in general, sort of low amounts of alcohol. So anyways, the results they summarized by saying they challenged the concept of a cardioprotective effect associated with moderate alcohol consumption in observational studies and suggested this result may have been due to residual confounding or selection bias, back to those two problems with observational studies. One other thing I'm going to talk about, that there have been randomized studies of the Mediterranean diet. So here's one that's a randomized clinical trial of primary prevention. That means you take people that don't have heart attacks and you try to determine if the Mediterranean diet might prevent heart attacks. It's called the PREDIMED study. And I like to say that the French paradox was revealed in this study, but without alcohol. What do I mean? Well, what I mean is that when they randomized people in this study, and they could either be randomized to their sort of regular diet or one that was a Mediterranean diet. There were two types of Mediterranean diets. But it showed that the Mediterranean diet was protective. The relative risks were 0.7 and 0.72. So it meant about a 30% relative risk reduction of having a coronary event. But the key point is that those studies, that study of the Mediterranean diet, were not randomized with respect to alcohol. So, because a lot of people consider alcohol as a part of the Mediterranean diet. But in this study, people were allowed to continue drinking as they did, and it wasn't part of the study. Then there was also another randomized clinical trial of the secondary prevention of cardiovascular disease. So that means it took people who had a recent heart attack and studied what happened to them if they also took a Mediterranean diet. And again, it showed these, incredible protective effects of the Mediterranean diet. But once again, this study was also not randomized with respect to alcohol. So if we remember back, the French paradox said that the Mediterranean diet, and probably the wine in the Mediterranean diet, was making people live longer. Well, from these two trials, what we can conclude is that the benefit of a Mediterranean diet, which is real, for the primary and secondary prevention of cardiovascular disease does not depend on, at least solely, alcohol consumption. Because these studies showed that the diet lowers, CVD events irrespective of drinking. So, one thing that's going to be coming soon. Yep.
Soon, just a few time for questions.
Yeah. Okay. Oh my gosh. Okay. So there is a trial coming of actually a randomized study to looking at drinking outcomes. And so to come towards the end, as Tim was suggesting, the real sort of million-dollar question for people in clinical medicine or in your own selves or public health is, should alcohol consumption be encouraged as part of a healthy lifestyle? I'm going to give you a couple of reasons why I think the answer is no. Again, no randomized trials. We see that observational studies, it's questionable about whether there's any protection left for mortality. And we also see that the better the study quality, the less evidence of protection. We also see that among better study designs, there's less evidence for protection. Also, we know that if we sort of recommend that people drink for their health, that not everyone will drink moderately. So that's something that's very important to consider. And the people that are sort of here a recommendation that drinking is good for you, we don't know how that plays out compared to a study population. So how do most people really drink? And a lot of people, don't drink in that healthy of a way. There are risks from low volume consumption. We've discussed some of them. Alcohol, even at low doses, is a carcinogen. It's classified as a class 1 carcinogen like tobacco smoke or plutonium. And it's associated very strongly with at least 7 cancers and probably several more. And we find in the United States that about 30% of all cancer deaths in the U.S. are associated with consumption of less than 1.5 drinks per day. And the last thing, and most importantly, is that no matter how, even if you assume benefits, that we think that alcohol causes net harms. And if we're going to try to say that something should be a preventive agent in the general population, if it's killing more people than it's saving, that's probably not a very good preventive strategy. So the dietary guidelines in the U.S. say it's not recommended that anyone begin drinking or drink more frequently on the basis of health considerations. WHO, no merit in promoting alcohol consumption as a prevention strategy. So my last slide is summary and recommendations. On a personal level, alcohol is legal and it's a source of enjoyment for many people, but from a clinical perspective in terms of health, drinking less, generally speaking, is more healthy than drinking more, and alcohol is a poor candidate as a preventive medication. From a public health standpoint, yes, alcohol is a leading preventable cause of public health problems, and it should be tightly regulated. We like to say, and I think there's good evidence for it, that actually having highly regulated alcohol pushes a lot of people who drink in clearly unhealthy ways into a more moderate group. And so if there are benefits from moderate drinking, having good policies may promote that. So I wanted to close and thank everyone for coming today. And most of all, I wanted to thank everyone at the Canadian Institute for Substance Use Research for having me and my family for this fall semester. And it's been a great time. And thanks. We have some time for questions.